Couple of disclaimers to start out with. As was mentioned in speaking with Kelly, we're interactive people, and there's a lot of information that's on there. I know you have them. Read them. I'm not necessarily going to be covering everything that's up there because I'd much rather talk about the issues at hand than pontificate a bunch of things that maybe I know, maybe I read, or maybe I stole from somebody else. So we'll be interactive as much as we can. My talk this morning is in two sessions. One of them may be a little more boring because it's a little bit about physiology, but I'm a big believer that you really need to understand the nuts and bolts of things to be able to deal with the consequences afterwards. I already used my yellow sheet because it was a comment that was made that's really very important to remember. And I think it creates this overarching issue with regard to why we're all here. The other, before I say that comment, the other thing is, if we look around the room, everybody in here is part of a team that does the same thing. Part of the connection that's not here, I represent. And in all fairness, they should be here too because they're the problem. And I know it, and you know it, and we'll talk about that. The reality is understanding pressure injury, as we're calling it in the 21st century, and understanding the ramifications and where it starts and what do you do about it, isn't necessary. It sort of rests on your back, but you didn't create it, and you're handed it. And the providers didn't create it either, most of the time. Sometimes they did, but most of the time they didn't. And they don't necessarily recognize it. And in my opinion, dealing in a big medical complex in Des Moines, the vast majority of them don't want to deal with it. And the reason they don't is they don't understand it. And I know you know that, and I'm not going to tell you that. But that's a base where we all come from, and that's a base where we all understand. But yet we're saddled with it, and we're saddled with having to deal with it, both from a financial standpoint for our institutions, but more importantly for the problems that it creates for the patients we serve. And that's probably the more important overarching issue that sits in the background dealing with pressure injury. Now to the comment I wrote down. Pressure injury percentages in hospitals are going up, and it's a linear, it's not a curve, it's linear, it's an acute angle. And there's a lot of research as to why. I think my observation is this. We have a lot more sick people in the hospital than we've ever had. And on a percentage basis, we don't have all those other people that used to get admitted to check their blood pressure. So on a percentage basis, we have sicker people with more challenges. People are living longer with more comorbidities. And that's part of the reason why we're seeing this upsurge or uptick in these kinds of events. But we're saddled with it, and we have to deal with it. So moving on, these are my relationships. For when we're supposed to say it, there they are. Okay. I want to talk about physiology of the healing wound because, as I mentioned earlier, it's very important to understand the basics. Because when one of these wounds becomes chronic or problematic, because not every wound is a chronic one, but they're all problematic, it's usually because something got unhinged in the normal healing process. Wound healing is a complex event. We all know that. Everybody in here at one point, or most everybody in here at one point or another, wound up having somewhere along the line somebody give a lecture where they talked about this happens and this happens and this happens. Now the interesting thing about wound healing is that they are not stepwise processes. These are processes that overlap, and one process triggers another. And unless these interconnected events occur, a wound can be stalled, or a wound can wind up being slow to heal, or even though we're not supposed to talk about pressure injuries not being a sequential event per se when we identify them, they are in fact. So yes, a stage 1 becomes a stage 2. I know we're not supposed to say that, because in the world of pressure injury, once we see it, it's whatever it is, but yes, they can. And unless we understand why that happens and try to intervene in the process, it's going to occur. It's just inevitable. This process that occurs in wounding is predictable, it's reproducible. Interestingly enough, it occurs in every organ system in the body. The cells are the things that are different, not the process. So an injured liver or injured spleen, maybe a little bit with the exception of bone, any soft tissue, the gut, whatever, the process is the same. It's just the cells that are different and how they trigger each other. But we're talking about integument here, and we're talking about skin and fat, and the bony structures underneath. And when we cut ourselves, and quite frankly, most of the patients we serve, if they cut themselves and you ask them a question, if you cut your finger, does it heal? Well, yeah, doc, or yeah, yes, nurse, yeah. I don't know why I've got this, but I cut myself and put a Band-Aid on it, and a week later I take it off and it's healed. In reality, it's not healed, but at least observationally it looks healed. The process of healing takes a course of about 18 months. We don't see it because typically the wound epithelializes, at least when we're talking about the skin, and what happens underneath is something that keeps going and we just don't understand it other than it pales out or it becomes more of a flesh color on the skin surface, but in the beginning it's red. Oh, by the way, when it's red, that's inflammation, that's part of healing. It doesn't mean it's infected, and don't put the patient on an antibiotic unless you're sure they need it, by the way. That's one of the mantras that I always talk about. Talk about saving money. That's the phase. And I always like to point out these are overlaps because things are triggering things as we move down. So things get mobilized and get processed, and one thing triggers another thing, and this process occurs. So we have inflammation. Inflammation creates an environment that occurs where platelets aggregate, platelets break down, they give up growth factors. The wound's got to have blood in it. If it doesn't, it's not going to get triggered to healing. That's really important. Obviously, one of the reasons we do a lot of debridement, there's data that says chronic debridement, even if the wound looks relatively clean, increases the trajectory to healing. That's true. And most of that has to do with platelet aggregation and breakdown and growth factors. Eventually, at least on a surface wound, we get a scab. The scab is nature's bandage. Don't take it off unless it's coming off because it's there for a reason. That's not eschar. That's a different thing, okay? Eschar is dead stuff. Scabs are important to the healing process. Underneath all of that, a granulation tissue, I usually like to tell people that's the scaffolding. A wound is a space. It's a hollow environment, and if there's no blood supply and delivery system to provide the things that wounds require to heal, they won't heal. And so this idea of developing this granulating tissue in the wound, that's really important. We usually tell patients, by the way, your wound's going to start bleeding. That's a good thing, not a bad thing, so don't get panicky when that happens. And then as that granulation tissue forms, fibroblastic proliferation occurs. I can never say the word. Keratinocytes occur and de-differentiate. Eventually we get epithelium on the surface of the wound. But that's not the end, because underneath the wound has to develop structure and the granulation tissue needs to go somewhere else. And it's that epithelium that's telling that tissue underneath to stop it and reorganize itself with the development of the connectivity of the collagen that's there. By the way, there's collagen at the beginning, but it also changes, and when it changes, that transition from the beginning phases of healing to the remodeling phase, actually the wound is weaker, and that's one of the places where in a hospital environment, especially in a post-operative patient, issues occur because people forget or maybe didn't realize that day 5, day 7 in a surgical wound, that wound's a lot weaker, and you've got to be very careful with it. Because it's the point of where the collagen may be beginning to de-differentiate, and certainly out at day 10 and 14, especially in critical care environments where patients may have been traumatized, they may have had a massive type of surgical intervention, they're in the ICU, they've got other things going on, and we're trying to get them out at day 10, 14, whatever, And now we have a patient that is at a higher risk than when they actually came to the unit, at least as far as their wounds are concerned. Eventually, the wound will de-differentiate and stop doing all of this, and that can, as mentioned in the slide before, take 18 months. Now, there's a lot, as I mentioned earlier, there's a lot of, it's really not folklore, but it's a lot of material out there, and medicine tends to do that, especially in medical education, because medical education tends to be more of a see one, do one, see one, hear one, do one thing. It's an apprenticeship program. It's always has been, and we have residents running around, and they have attendings who may or may not explain things to the residents, so they have to kind of figure them out themselves. If you're in a teaching hospital, you know what I'm talking about. The residents have a lot of book smarts, but not necessarily a lot of practical ability. And so there's a lot of semi-truth being handed from one generation to another about things, and we all see them. And those are things that I always used to like to tell our residents, you don't do it because I did it, you do it because it makes sense. You do it because there's evidence that says you should do it, and if I'm doing something where the evidence says I shouldn't do it, then tell me because I shouldn't be doing it. It's not because, in my case, Dr. Cooper, Dr. Silverman said I did it this way, you do it this way. It's because the evidence says that's how we do it. And one of the things that we're all in an environment, in our environment now, is dealing with evidence and making sure that our outcomes are based on the evidence. And it's not C level, preferably A, most things are B, and those are the kinds of information we should be sharing with each other and we should be learning from. Now, in many cases, when we have a patient in the hospital, especially not to readmits, we'll talk about that at some point, but the patient comes in the hospital and has multiple issues. And typically, as I mentioned earlier, and as we all know, our current climate of patients is the sickest we've ever seen, and quite frankly, 10 years from now, they will probably be as sick, if not sicker, because of just the natural way in which medicine and healthcare has been going. They may or may not come in with a wound. We may create a wound, a surgical wound. What we don't want to do is have them suffer for something that we're sort of ignoring in that process. And again, this is all about pressure injury, but it isn't just pressure injury, it's other things. It's bacterial contamination and development of biofilms and things like that in our environment. I always like to tell patients in our outpatient clinic, you don't want to go in the hospital. No, we don't want you to go there. We'll treat you out here because the hospital is a petri dish, and you're going to get sicker if we put you in there, and we all know that. The regulators don't understand it. Or maybe they do. The payers don't understand it. It's not anybody's fault, but you're aggregating all these sick people in one spot, all of whom have some kind of biofilm on their body with some kind of organism, and then we're using various treatments to try to reduce the biofilm, and we wind up with organisms that are difficult to manage. In the same vein, we also have these patients with these comorbidities who are winding up developing pressure injury. And the pressure injury is a result of multiple factors. It isn't because, and I'm an expert in a case in Chicago coming up, a defense expert, where the hospital system is being sued because a patient developed a pressure injury, and the plaintiffs are arguing that it's because they ignored it. They did not. They did not. It's all there. The patient's comorbidities unfortunately created an environment where it was inevitable. And we're going to talk about avoidable and unavoidable here in a little while, but in this case it was inevitable. And actually, in my opinion, the hospital staff, personnel, and attendings did the best they could to try to minimize the impact of this wound in this patient, and they did, actually. I kind of think it's a frivolous lawsuit, but it's going on, and that's why there are plaintiffs' attorneys, I guess. We all know that chronic wounds and pressure injuries, but chronic wounds are a huge burden. Some estimates say 50 billion. Pressure injury, I got a slide here. It's not that much. It's about 10% of that. That's a lot of money to be spent on something that's iatrogenic, meaning it occurs because something else happened and created it, not a disease. All of these things, if we look at a wound and a pressure injury, we have all these comorbid events, both systemic and localized, which create an environment which might create the wound and can delay healing, and especially in pressure injury, create an environment where it goes from a reddened area to something a lot more risky and a lot more dangerous. Now, one of the things about chronic wounds, and the reason I talk about chronic wounds is, quite frankly, pressure injuries wind up being that. There's very few pressure injury, other than maybe a stage 1, that occurs in the hospital that heals, at least in front of people during the short stay of the patient, and then they go to a long-term care facility. They wind up becoming a different environment, and they're the same environment that a chronic wound occurs. The normal healing process is disrupted in a number of ways. In a pressure injury, usually there's a bunch of comorbid events, regardless of or whatever they are, and those are not necessarily totally adjusted during the patient's stay. They may have hypotension, they may have labile blood pressure, they may have poor vascularity, they may have inherent atherosclerosis in the capillary bed, may not be very robust, they may be a diabetic, and the inflammatory process is creating an environment where the healing process is even disrupted in its base layer, and the biochemistry doesn't work. But these comorbid events usually are there. Now, hopefully they're off the ventilator, or they're off the balloon pump, or they're not sequestered in a bed where you can't move them or you can't turn them. But those comorbid events are there, and it disrupts wound healing. And when it disrupts wound healing, the pressure injury becomes a chronic problem. Chronic in the sense that it isn't going to heal in front of you during that hospital stay. As I said, there's a lot of things here that I want you to read that I'm not going to get into. So now, some fun facts about pressure injury. They've been recognized as disease entities since probably 5,000 or more years ago. Actually, if you read the Hippocratic papyri, there's a discussion in there of them. It described pressure ulcer in association with paraplegia and a patient that had bladder and bowel dysfunction, and it should be 100 years old. Charcot described the cubitus ulcer, old term, don't use it, even though it's ICD-10, you can find it in there, and described it and called it something like gangrenous pulmonary metastasis and spinal cord invasion. So those things are there. This environment that I'm talking about, where pressure injuries act like a chronic wound, is an environment of a delicate balance between normal and abnormal physiology. Claude Bernard, famous scientist, actually spoke at my medical school graduation, is Canadian, talked about the internal and external milieu and the balance between those things. Patients that have local issues, and especially in pressure injuries, we see necrotic tissue breakdown. Typically, there's a high bacteria burden or biofilm, which I'll talk about. They are in an environment which is not necessarily very, certainly not sterile, typically not clean. Some of that they bring in with them, but because of their incompetence or immunocompromised state, they wind up becoming a host for that to occur. Typically, the critical ill patient or the patient that's going to develop a pressure injury has a high level of exudate. That creates a high level of metalloproteinases, which are both good and bad actors, and depending upon where they're present in the patient and the wound. Typically, the patients have other issues. Maybe they're thrombocytopenic, which means the growth factor levels are down, or circulating growth factors are down. They may be nutritionally compromised, both chronically and acutely. You're going to hear a lot about this afternoon. When I say chronically and acutely, there are two different things going on there. The patient may come in with some type of malnutrition, not necessarily overtly or grossly, but let's say undernutrition because they've been sick for a while. Metabolically, they've changed the way in which they're managing energy. They're now catabolizing their lean body mass, which then creates another problem for pressure injury because now the cushioning between the bony prominence, the skin, and so on is being disrupted. They may be catabolizing their fat. It's further being compromised. Oh, and by the way, when you have a wound, the body doesn't know that you're otherwise sick, and so all of that protein's trying to go to the wound, and then all of a sudden all these other organ systems wind up being compromised because there's not enough energy to go around or enough amino acids for repletion. I'm sure the dietitians will talk about that later this afternoon. A whole bunch of other things are happening in these patients. The extracellular matrix is corrupted. In many cases, their patients are older and there's something called cellular senescence. It's another whole discussion about why, as we age, we don't heal the way we used to, but it's a problem. Tissue hypoxia, they may be hypotensive. They may be, typically their tissue oxygen tension is down. Yes, we're giving supplemental oxygen when they're on a ventilator, but by the way, circulatory-wise, they're still not bringing all of that oxygen to the tissue where it's necessary. And they may be getting repeated trauma. They're going to X-ray, they're having a CAT scan, they're going to MRI, they're going to the OR, they're being moved here, there, and yon. And yes, the nursing staff is trying to do their best. They've got a Braden scale risk index. They know they've got to turn the patient. They go to turn the patient's getting an MRI. They know they got to turn the patient is off somewhere else getting an X-ray. And it's disrupted care. I don't have an answer for it, by the way, but that's what's going on. And I know I'm preaching to the choir. I wish I did. I mean, with if we had enough money, just an MRI in the room or something, or hang. I like to say, no pressure injury, we'll just build hospitals in outer space. Get sick, you just get up there and where there's no gravity and we don't worry about it and move on, and we don't have pressure injury to worry about. And of course, this is another whole issue with regard to radiated skin. I'm not going to talk about that today. That's another whole lecture. And then the patients bring things with them which we have absolutely no control over, and often they're not controlling. The more common ones, diabetes, anemia, malnutrition, immunodeficiency. They may be on immunosuppressive medications. We can't do anything about age. We're trying to do a lot about that, but it isn't working. But we're probably the only thing up here we're making some inroads in is that thing there. And we don't know about the vaping as to what that's going to create as we move on. We have a tendency, and these are sort of universal slides, because we have a tendency to separate all this stuff out. Venous ulcers, pressure ulcers, diabetic foot ulcers, arterial ulcers, et cetera, et cetera, et cetera. Probably it's not warranted to separate them out in terms of their etiologies, or excuse me, we separate them out because of their etiologies, and we may separate them out as to how we care for them, but in the middle, they're kind of all the same thing. The problem is a tissue that's not healing, and we have to address them, and this is something called unified wound theory. And we've always tried to figure out what is it that puts them all together. And in the 21st century, we're talking about biofilms. We talk about them a lot. All pressure injuries have biofilms. Asterisk, maybe not stage 1s, although even there the skin has a biofilm on it. This is the area of research currently I'm actually involved in, is how do we break down this biofilm, this tenacious fluid which you don't see, it's there, sitting on the surface of the wound that creates a safety environment for bacteria and fungus and probably virus. There's not much research there yet. And it impairs all of the wound healing process. Host defense is unable to get in there. And by the way, the bacteria that lives there shares their DNA, and they wind up making organisms that don't exist in the real world, in which case we may do some kind of a culture. Typically, it's the wrong kind. And we get an antibiogram that gives them, okay, it's predominantly Pseudomonas or it's predominantly X, Y, or Z. We put them on an antibiotic and we're treating the wound and they're not getting better. That's because we're not actually culturing out the bug that's the combined bug of the DNA between the two organisms. So a lot of research being done on biofilms, and if I would say there's going to be any major advance in the treatment of these things moving forward, it's going to be in this area, because we're moving to a time where you're going to take the fluid from the wound, you're going to send it off to the lab, you're going to be looking for some markers, you're going to get back a lab data that's going to say this is the DNA issue going on here, use this, use that, and so on. We're not there yet. We're getting close, though. It's interesting. I mentioned, or when I was asked to talk, there was a list of things, and I know there's a dietitian coming. One of my areas of training is interventional nutrition. I was one of the first people to come out of the Penn program. And so it's sort of close to my heart. It's most of where I've been doing my writing in nutrition and wound healing over the last 20 years. And you're going to hear a lot about this later, but I wanted to take a moment, sort of a segue, to say the key to understand the role of nutrition is to understand where intervention will help. And unfortunately, the intervention isn't going to prevent a chronic wound, except where a wound occurs because a patient has some kind of nutritional insult, which is really rare. So most of what we do in the nutrition world, with especially pressure injuries, is adjunctive. There's some really neat data from the 70s where Mitch Kaminsky in Chicago and his team put a bunch of patients that had pressure injury on IV nutrition, at the time called hyperalimentation, for those of you old enough. And those patients did better than the other patients. And that was a landmark paper. And everybody said, wow, we got to put all these people on IV nutrition. Not really. Because when you really unbundled what they were doing, they paid more attention to the nutrition inadequacy of the patients that were on IV nutrition, because it's the nature of intravenous nutrition, total parenteral nutrition, because in order to provide it and to give it appropriately, especially then, in its relative infancy, was the lab data and so on and so on. So they were really more on top of those patients. And if you really unbundle what they just did a better job of making sure nutrition adequacy was maintained in a group of people. And the other group, the control group, they didn't do as good a job. And it wasn't that the IV nutrition made the patients heal. It was they were doing their job. They were making sure the patients had appropriate protein intake and appropriate carbohydrate metabolism, and electrolytes were appropriate, and micronutrients were appropriate. In the other group, they were measuring it, but they weren't doing anything about it. So there's this, again, back to the science in snake oil. That information from the 70s and 80s is talked about a lot, but really you have to unbundle it and say, well, yeah, but it's not because they fed them by vein, it's because they actually fed them. And they were paid attention to that. Now, that's not to say that adequate nutrition is not important. Of course it is. And there are a bunch of different places that extol it, so to speak. Obviously, the National Pressure Ulcer Advisory Panel has a white paper on it. The European Pressure Ulcer Advisory Panel, the Pan-Pacific Pressure Injury Alliance has a white paper, et cetera, et cetera, et cetera. And the American Society of Parenteral Nutrition has all kinds of information available about the role of nutrition in wounding, and especially in pressure injury. If we look at patients' nutrition status and wound healing, and again, it's not any different than the idea of this unified wound theory in pressure injury of any other kind of nutrition. A well-nourished individual, the inflammatory process is normal. There's nutrient availability. Even if there's an anabolic environment, the tissue repair system is going to work. And also, if we think about a preventative perspective, in the well-nourished individual, they are at less risk. Doesn't mean they can't get a pressure injury. Of course they can. But it isn't because of the nutrition defect. the nutrition defect that, if they have a nutrition defect, they're at more risk. If they don't have a nutrition defect, they're still at risk. It's just this isn't part of the balance sheet, and it's other things. People that have undernutrition, malnutrition, depending upon how we want to define it, nutrition defects, some of which may be metabolic and intake specific, some of them may be secondary to medications they're on, especially patients with malignancies that are taking various kinds of anti-metabolites, creates a physiologic environment which even for the most astute clinician is extremely difficult to intervene and maintain a normal homeostatic nutrition environment. It is, I won't say it's impossible, but there's something called tumor necrosis factor. Tumor necrosis factor is elaborated by the cancer cells themselves, putting the patient on an anti-metabolite to try to slow down the metabolism of the cancer cell. May or may not do a good job, but guess what? It also does the same thing to all the other metabolizing cells and creates a malnourished environment in and of itself. The cancer creates it, and then the therapy creates it, and then the caregivers are being asked to try to overcome that by various kinds of nutrition manipulations. We do a fairly good job of getting close. Unfortunately, we don't do a great job of overcoming all of those things. And again, that therefore puts the patient at risk for further tissue breakdown and lack of repairability. The inflammatory process winds up becoming misaligned and not that it's non-functional, it is functional, but the problem is it's misaligned to do its job. And when that happens, the wound can actually devolve. For a wound to heal, inflammatory response needs to be robust. If you put the patient on something that is antagonistic to the inflammatory response and trying to deal with the underlying disease, you may be doing a great job of dealing with the underlying disease, but by the way, that inflammatory response needs to be robust for a wound to A, not form, or B, heal, and now it's not working, so guess what happens to the wound? It gets worse. Catabolic responses to wounding. Wounding is stress. Pressure ulcers are stress, regardless of whether they're stage 2, 3, or 4. That the stress is there. Bigger wounds are obviously more stressful because it's a bigger metabolic environment, but the depth doesn't necessarily mean that it's more of a stressor. It is a stressor, and a bunch of things happen. And those things from the wound alone create this stressful environment on the body economy. All of these things occur, and unfortunately, most of those things are sort of cyclic in nature and further stress out the physiologic response to wounding in an attempt to get it to heal. Again, in the face of a patient that's already downregulated in terms of their metabolic response to whatever is going on. I'm sure you're going to hear a bunch about this afternoon. Please understand that the most important thing in wound healing is protein, and in the body economy, it's amino acids. We've got plenty of amino acids in our body. We've got a bunch that we need to get from the outside, but the good news is for wound healing, most of them are there. The two main ones are these two. I'll get on my soapbox. Giving a patient this or giving a patient that isn't going to make the wound to heal. Ross Labs would be very upset with me because they make a lot of money selling supplements. Typically, these are not deficient physiologically. Adding them in is nice on paper. It looks good, but unless the patient has some kind of amino acid defect, probably, I always like to say, yeah, let him eat a chicken. Probably more intact protein and better. Obviously, protein requirements of wounding are upregulated, and it's important to make sure that we're managing that. The more important thing is what is the protein requirement? Typically, in an ambulatory adult, it's about 1 gram per kilogram, roughly, if you're not sick and you're not otherwise. And then it gets upregulated depending upon what's going on. And patients with pressure injury, especially large volume pressure injury, are kind of like burn patients, and so that nutrition requirement in terms of their total caloric need may be upregulated to 1.5 times per kilogram, or even 2, and that's kilogram of actual body weight, not ideal body weight. Those patients don't need to be on a diet, and we need to make sure that that's provided, and that's a balance of protein, carbohydrate, and fat, because what we don't want to do is give them free fatty acid deficiency. The energy requirements are upregulated, and it can also come from the catabolic response to the wound. That's one of the reasons why we have to crank that up and sort of, we think, overfeed them, but we're not doing that. We did that for a while in the 80s and probably killed a bunch of people by giving them 3,000 to 5,000 calories a day IV, but we learned from that. Nutrition defects alter wound healing. They do. They are, especially in starvation, or especially in a patient that's in a critical care environment where we're trying to catch up with the nutrition. They're hopefully being enterally fed in the gut or IV nutrition, which we don't use as much anymore because we know it's not as effective for other reasons. The problem is that the nutrition defect that's occurring in all of this going on can actually wind up becoming a process that leads to this wound becoming a chronic, difficult wound to heal at the point at which the patient is going to be dismissed. Oh, and by the way, that 30% readmission rate for that pressure injury patient that left and came back because the wound got worse or they got septic or whatever, a lot of that falls on this. Not all of it, but much of it. That's just not, there's many complexities in these people, and that it's not that it gets ignored, it's just that it just doesn't get given the import that it needs. The other area of nutrition is micronutrients. You read a lot, hear a lot. Most patients don't have micronutrient deficiency unless they have some other metabolic issue. We've got way more supplementation of micronutrients in the diet in this country than we need, and it probably leads to some negative outcomes in and of itself. Just read what's on the label of many things. So we don't necessarily see zinc deficiency. We don't necessarily see a magnesium deficiency unless medicine's caused it. But in the patient that has a pressure injury or the patient that is being managed in the hospital where we're controlling everything that's going in, we have to be sensitive to the fact that the micronutrients, especially things like zinc, et cetera, are important. The data, unfortunately, is sea level, and that's one of the other problems with nutrition intervention and wounding and managing, is that most of it is anecdotal, most of it is observational. In fact, most of the research data with regard to the management of wounds in general is all sea level and anecdotal, and that's because there's not a lot of money in it for the drug companies to spend a fortune in appropriate kinds of research. Doesn't mean it's bad, it just means it's anecdotal. It means that it's based upon observations that people are making. Get on my soapbox again. Supplementation with 1 or 2 amino acids or micronutrients without documented deficiency does not enhance the wound healing process, but it does increase the bill. A patient that's lost more than 10% of their lean body mass, the wound then can take priority over their physiologic stability. That's not a lot. 10% of lean body mass, most of us would like to lose that. And once that happens, and that often happens just prior to admission, and it certainly happens when the patient winds up getting admitted to the ICU. When their serum albumin drops, that's not because, by the way, that's not malnutrition. Understand that. That's a metabolic response to their illness. But it is telling us that they are not metabolizing protein the way they should, and therefore their serum circulating proteins are being affected. Doesn't mean that it really doesn't mean they're truly malnourished. It means that their metabolic or catabolic response to injury has been upregulated, and we have to deal with that. And that is really difficult because giving them more doesn't necessarily do that. if a patient has lost more than 30% of their lean body mass, as we see in the catabolic cancer patient, they are at maximal risk for developing spontaneous wounds. And those are the people that wind up developing the pressure injuries that are the absolutely unavoidable ones. And that's one of the reasons why the NPAUP came out with the paper, whatever it was, because they got off their pontificating high horse that nobody should ever get a pressure ulcer, and everybody was screaming, that's nonsense. And they finally said, well, yeah, once in a while somebody's going to get one no matter what we do. By the way, that's out there. And I think it's this month, next month, their new regulatory statement is coming out. Another thing I just, in the last couple of minutes here, sarcopenia, loss of muscle mass in older adults, and also in people with cancer, and people that are not active, and people that are otherwise metabolically injured or have some other kind of comorbidity, creates a problem which can result in spontaneous injury or at-risk increase. So another one of the problems. People with pressure injury, this is just tells us that if they have a stage 1, which is blanched red skin, I mean, how can that upregulate? Guess what? It increases their caloric needs. Stage 2 increases it even more. Stage 3 in more, and so on, to a point where they may require a double of regulation, 2.2 grams per kilogram of protein, as opposed to normal 1 or 1.2 kilograms, which I mentioned earlier. Got to be really careful of the nutrition data, or not the nutrition data, the data in wound management. If it's rat models, it's really interesting, but rats make growth hormone over their entire life. So we don't, and that would be great if we did, because we would probably do a much better job of healing these wounds, but we don't. And certainly once we get past our 20s, we're not making growth hormone. It's good news, bad news. And rats do, so we got to be really careful on the rat model. All right, 5 minutes. Whew. Questions, comments, collaborative. Nothing. Over here.
So the slide that you showed us on the upregulation of nutrition needs, is it better for us to supplement with zinc and vitamin C, et cetera, without having documentation for that, but to assume that there probably is some increased need there?
Short answer, yes. Long answer, maybe. We don't know. The problem with all of this is the data. The data's not robust. It's there. I mean, just a sort of a sideways. Debbie Johnson, who's at the University of Wisconsin-Madison, and I wrote a chapter in the third and fourth volume of Diane Krasner's book on nutrition. And we wrote the third one. We were looking for this kind of data. It's not there. When we revised it, we found data that was still, maybe it makes sense, but the good news is, unless there's a contraindication medically, you're going to pee the zinc out, so don't worry about it. Give it to them. And by the way, that stuff's inexpensive, so why not? The problem is the expensive stuff, we need to be more mindful of its use. You know, IV glutamine and things. That data is it's not so great. But yeah, of course.
And then your comment about the grams of protein per kilo, use actual body weight. Morbidly obese individual?
The problem we have with that is nobody has an answer to that, because it's hard to identify what their lean body. It's supposed to be lean body mass, actually. Adipose is not metabolically active, and we know that it's been sequestered in a patient that's critically ill. Fat's not, it's there, but it's just in the way. So they're catabolizing their lean body mass. They're pulling out those branch chains, creating an energy, and we have to supplement that for sure. The rule of thumb is probably their estimated lean body mass, and then a little fudge factor up. Again, It's more of a concern on the expense side, unless they're in renal failure or liver failure, then you've got another whole set of rules.
So it may be an adjusted body weight.
Yeah. Yeah. And then you're going to be managing in a morbidly obese patient, and now morbidly obese is the numbers are staggering as far as what is the BMI. The reality is you're going to be managing and you're going to be watching and you're going to adjust based upon some data you're going to collect, which hopefully you can regulate. But micronutrients is not the issue, sure.
How do you determine the glutamine and the alanine deficiency?
You don't.
Okay. So how do you know?
They're not.
Okay.
That's my point. Arginine, glutamine, alanine. You're not. If you are, you're dead, because it's in your muscle mass. And as long as you have muscle mass, your body's stealing it away.
So you said that we don't need to supplement that?
Separately. That's my eat a chicken, intact protein.
Okay. Gotcha.
Okay, if you're feeding the patient by enteral means, then it's going to be some kind of peptide formulation, because most of these people are not metabolically active enough to break the protein down, and that's fine. But individual amino acid supplementation was sort of the vogue of the 90s, and there's just no data that it makes sense. There's some data with regard to certain diseases and some other things, but in a general world, they need intact protein. They need a supplement. If they can manage it, that's what they need. Berry picking different amino acids, especially in wound care patients, no. There's just no data. It doesn't even make physiologic sense that you would want to do that.
So giving them arginine isn't going to be...
Waste of money.
Okay.
Ross Labs hates me.
I see that a lot in the nursing homes.
Well, yeah,
In
because
my area,
here's the
they're
reason.
doing the
Why?
arginine.
We have anybody here from long-term care facility? We have a dietitian, though. Where's the dietitian? Where's our dietetic people? So how many times does the rep come in and say, well, you got to give them arginate?
We haven't seen a rep for a couple of years, but we did get a
Yeah,
hard push
yeah.
a couple of years ago.
Yeah. You do know that some of this stuff comes out of I'm just going to be quick anecdotal. I know we're going to take a break here in a minute. Anecdotal story. I'm old enough to know of a product called Vivanex. Anybody remember that? I know B knows. B and I are from the same era. So the reality is, do you know where that came from?
Yeah.
Astronauts. In the 1950s, that was developed by Norwich Eaton Labs in upstate New York. Actually, I did research for them. And that was developed as a low residue protein supplement for astronauts. Because what was in there? Amino acids. That's it. And some glucose. And that'd be great, so they don't have to worry about the astronauts pooping. Because there's no poop stuff. And whatever's there, I mean, they're going to shed cells and things, but certainly there's no fiber. So they did it, they developed it, they did a ton of research on it. They got a grant from the federal government, NASA. Norwich Eaton Labs developed it. It was intact, it had all the amino acids in it, including the essential ones. And they went to Houston and they gave it to the astronauts and they said, over my dead body, I am not drinking that. I'll use the word crap, because that's what they said. There's a famous quote from Gus Grissom about that. Okay, so here's all this R&D with Norwich Eaton. The astronauts aren't going to drink it. And somebody said, maybe we can give it to sick people. That's how Vivanex started. That's how it started. And so they sold to the medical community. Now, the good news is it made sense at the time. It doesn't now, but it did then, for what we knew and what we understood in the 70s and 80s about enteral nutrition. We know now, probably not individual amino acids, because they don't necessarily get absorbed as quickly or translocated as quickly as peptides, but a good idea. And then we get to, all right, somebody wrote a paper in the 70s or 80s about arginine and its importance in wound healing. Absolutely important, but so are all the other 22 amino acids. And some lab, I think it was Ross originally, said, well, look at this. By the way, I did research for them too at one point, Abbott Ross, not Abbott Ross now, I don't even know who it is. And we'll make a supplement out of it. And we'll give it to our sales force, and they're going to go out there and they're going to sell the heck out of it. Except there's no science. Eat a chicken. I don't like chicken, but eat a chicken. Any other questions? Yeah.
Dr. Zagoren, one of the things that you said at the very, very beginning, and I'd be interested to hear what everybody in the room thinks about. There's somebody missing here today, and that's our providers. And so I would like to know from all of you, do you feel like you have good provider involvement? And if so, how have you wrangled that? And if not, Dr. Zagoren, what are your ideas about engaging the providers?
Well, we have time?
Yes.
Yeah, we're fine.
Okay,
Yes.
we're good?
About 10-15.
Yeah.
Okay, well, I was trying to, I know you were gonna raise the thing.
You're not quite there yet.
Oh, well, let me go back about 5 slides. A provider. I'm a provider.
Yes.
Yes.
But I'm in a unique position. And that is, I'm the medical director of a wound healing program that encompasses 5 institutions. So I have some power, because that's administrative power. And I can tell you what we're doing. Besides educating the staff on each of our units and having wound champions, and I heard various different combinations and permutations of that around the room, because each institution has their own thing. We're trying to, at Unity Point in Central Iowa, or in Des Moines for now, as Kelly's part of the team, and she was saying, what are we doing? You're not doing it yet, but it's coming. We're developing a wound healing collaborative, and we're trying to take it away from the provider. And believe me, most providers would be just happy enough not to deal with it. But again, we're huge, and we've got a lot of people and a lot of personnel. Our wound care program is we're not a profit center, as we all know, but we're a savings center. We save money. That's the way in which administration looks at us. And we are putting in place a process where the wound and ostomy staff, the outpatient wound care team, is going to be all one thing. And we are going to be we're going to know about every wound in any one of our 5 institutions, whether it be a fresh surgical wound or whatever. And that's going to be put on a wound care team thing. We don't know exactly what we're going to call it yet. And we're going to be setting up policies to address that. We already have them, but it's going to have some teeth, because it's theoretically provider driven. I mean, I can diagnose, or my provider team can diagnose. We can write orders. I know nursing can't. But this will give us some sort of other segue into how are we going to deal with the injuries in the hospital. The other thing is we're going to be educating. We already are, but educating our staff, our provider staff, about red flags, and it's important if you do see a wound, re-educating them on staging and so on. I understand that it's a never-ending battle, and in smaller institutions, there are probably similar kinds of processes that you can do. And I'd be more than happy to talk individually with any one of the institutions to try to help you work through it. But I get it. And if I put my trauma surgeon, ICU, critical care hat on, that is the last thing I want to worry about. And I get it, and I understand, and I feel for that. I was there. The good news is I don't do that anymore. Thank you, Lord. But it needs to be part of the discussion, and it needs to be upfront to the providers. And quite frankly, what we've decided is we're going to just take it out of their hands. We're going to make it so they don't have to worry about it. Educate them, make sure they're aware and sensitive, but set up a system where we're going to control it in a much more cohesive fashion. Give me about 2 years, I'll come back and tell you how that's working, because we're just putting it in place now. We've been working on it for a couple of years, and it's about to hit the ground running in the spring. But it's education, obviously. And it's also a sensitivity that, unfortunately, unless you bleed, you bleed or you're hurt, you're not going to be sensitive to something. So there needs to be some kind of a hammer. The good news is our medical staff vice president, Mark Pirtle, he's a hammer. So you don't want to call from him. And those are the kinds of things you have to do. I wish I had an easy answer, but on an individual basis, there are different things. Most of it's education and sensitivity, making sure the providers are aware that that's an issue. Again, they're focused on blood sugar control, blood pressure control, circulation, breathing, whatever. And it's a narrow focus. Even the hospitalists, I mean, in those institutions that have hospitalists, that's probably where you would start on an education process. You don't have hospitalists in a smaller institution where you're dealing with community providers. It's education, 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 and sensitivity training. I wish like I said, I don't have any other answer.
What are a couple ideas you can give our hospitals that are here today to try to identify a practitioner champion, to somebody that their go-to person? Is that valuable, and what are some tips?
Well, of course it's valuable. I mean, it's finding the quote unquote skin champion is tantamount to success. I wish I had a specific area. You know, maybe one thing I could say, bless you. One of the things I might say is it's not going to be somebody that's a graybeard, because their habits are taken care of and done. So that's not going to happen. I never thought I'd say I'm a graybeard. Well, I'm not, but I'm close. But it might be somebody that's more younger and aggressive. That's and it should be somebody that is not necessarily on the fringes of the hospital staff, but somebody that's engaged. Usually that might be a medical staff president or whatever, however you designate it, sit down, hey, we got this problem, what are we going to do? Because typically people that want to shoulder that responsibility, besides having big egos, don't want to look bad. I mean, you have to feed that ego as well, but they don't want to look bad, and typically they're doing that job for the best interest of the institutions, not just themselves, to put it on their masthead. But I wish I had an answer. I just don't for that. When we have it, and we're in the middle of trying to find a replacement for me, because I do have an exit strategy, and it's not easy. We're in the middle. I just interviewed somebody last week who was a former resident, who at least I know has been trained in wound care, or wound. It's not so much wound care. He's a surgical oncologist, but he understands it that way.
What does provider level training encompass with a lot of critical access hospitals? So yes, community providers. So in our newer practitioners, what does wound management education encompass? So we're aware of maybe their knowledge base. Well,
it's interesting. Wound care and B and I go back to the beginning of interventional nutrition. And wound care is sort of 5 minutes.
Yep.
Wound care is very similar as to where nutrition was, not necessarily at the beginning, because it's become a very robust environment. The reason is a lot of money in it, that's why, but not a lot of money for the practitioner. I think it's creating an educational environment for the medical staff. Having somebody come in and say, that set of slides I can use to talk about a whole bunch of things. Hey guys, chronic wounds cost money. And if we can't afford it, if you want to have an institution to practice in, we have to deal with this. There's lots of other issues, but this is a big one. And we have to deal with it. And it's sensitivity training is what it is, awareness training. It's almost like all the training we've been going through, everybody now, with regard to active shooter stuff and so on. It's sensitivity. And quite frankly, if I was going to design a program to sensitize the medical staff, I'd probably use some of the active shooter training materials and change them with regard to development of pressure injury, et cetera, or iatrogenic injury in the hospital and APUs and so on, because I don't know that the providers truly understand the ramifications of where that's going, especially with Medicare, CMS as we move forward, and we all know what's coming down the line in terms of the penalties and so on. They got to know, and it may be an institutionally if you don't come to this, you're not gonna be able to admit, because you're gonna have to come and you're gonna have to provide the training. Most institutions or licensed, I'm not saying that the medical board's gonna do it, but in order to be on the medical staff, it may be that you have to attend a lecture. At least you sensitize, what they do with it, I don't know, but sensitize them to it. We have 1 minute, if that clock's correct.